Good evening, everybody. We're going to go ahead and get started. There will be some more people joining, I think, over the next few minutes, but we wanted to get started right on time. Welcome to our very first episode of Focal Point, presented by Aniridia North America. My name is Janelle Collins, and I serve as the member at large on the board of directors for Aniridia North America. I live in Florida in the United States with my husband, my two children, and actually a tortoise and a bunny. My awesome 14-year-old daughter has aniridia, so that's how I'm connected to the aniridia community. Now, our guest tonight is Dr. Peter Netland, and I know for many of you, he doesn't require any introduction, but for those who aren't familiar, I wanted to give some of his background, and it is too numerous for me to memorize, so I'm going to read it to you. Dr. Netland is the chair of the Department of Ophthalmology at the University of Virginia and the chair of the board of Aniridia North America. His research interests have focused primarily on glaucoma, and he's an active clinician caring for glaucoma patients. In addition to his recognized expertise in the clinical management of glaucoma, Dr. Netland is a prolific investigator, having written hundreds of original scientific articles, book chapters, reviews, and published abstracts. He has published 6 textbooks, delivered numerous named and invited lectures on the management of glaucoma, has been director of a long-standing glaucoma fellowship program, has served in leadership positions in medicine, and has received numerous rewards. Dr. Netland became interested in aniridia over 20 years ago through experiences with patient care in patients with aniridia. In the years since, he has been increasingly involved in patient advocacy groups, research, and clinical care for patients with aniridia. He currently serves as the clinical director of the Congenital Eye Disorder Program at UVA and was a principal investigator in the Adelern clinical trial for aniridia. On a much more personal note, Dr. Netland is one of the kindest, most patient doctors I've ever had the privilege of seeing with my daughter. Having worked with him on the board of ANA, I can attest to his heart for the aniridia community and for how much this community means to him. Thank you, Dr. Netland, so much for taking the time to join us here tonight.
Well, thank you, Janelle. What a nice introduction. I really appreciate it. And it's great to have the opportunity to do this tonight. I'm really excited about it. I think we're going to go through some basics about glaucoma and aniridia and glaucoma to get oriented a little bit. And then we'll move on to some questions. I think we'll try to spend the majority of our time actually interacting. Right now, I feel like there must be some people on that I probably know, and I want to welcome people personally. But I will tell you that I'm not able to really look at the audience right now because I'm screen sharing. So as soon as I shut down the screen sharing, I'll be able to see all of my friends out there, and I'll look forward to that. So in the meanwhile, I do want to go through some basic material about this topic. And so this is going to be a focal point, our inaugural focal point actually about glaucoma in aniridia. And as Janelle said, I'm at the University of Virginia School of Medicine. I have no conflicts of interest at all. And so let's see, I've had a little bit of, there we go, trouble moving the slides, but they seem to be working okay now. So glaucoma, what is glaucoma? Well, we're going to get to that. But it is a major health concern. It's potentially vision threatening, and the good news is that treatments for glaucoma are effective. But I guess you could say the bad news is that glaucoma is common in aniridia. In fact, it oftentimes occurs in childhood. This is a photograph of an infant here, but it can occur that early, but usually it's a couple years later, and you'll see, you'll hear more about that as we go along in this. So what is glaucoma? Well, we try to describe it through a sink analogy for a part of it. And the one way to understand it is to think of it like a sink. And the eye is sort of like a sink. You've got fluid flowing into the sink through the faucet, and then fluid coming out of the sink through the drain. On the left-hand side, you see a normal situation where the faucet is on and the drain is flowing there at the bottom, and the water is coming out so it doesn't overflow the sink. The water is coming out the drain. But in the glaucoma situation, there can be a blockage of the drain. And so you can see the water flowing in at the same rate, but eventually it flows over the top and spills over. And so if we think about it in the eye, it just builds up inside the eye if there's a blockage of the flow going out, and the pressure can go up in the eye. And when this happens, you can get damage to the retina and optic nerve, and this ultimately can lead to loss of vision. So the things that we see in patients with glaucoma are oftentimes elevated intraocular pressure, and then we can see the retina and optic nerve damage in the image to the right. There you can see a picture of an optic nerve. There's some pink tissue around that circle, and that's the actual nerve tissue itself. If the nerve tissue is thinned, then that can happen in glaucoma, and that's because in that situation you can see some damage to the nerve tissue. So if this happens, then you start getting the damage to the nerve tissue in the retina. You can have visual field loss, and the image below shows an example of that on the left-hand image of the two people in the kayak. So you can see that the whole image is there, but if there's a situation like glaucoma with the visual field there, you can see that it starts to, the peripheral part of that image is gone. And what happens in glaucoma is the visual field loss occurs from the periphery first, moves towards the center, and ultimately you can lose that central vision too. And then you can still have a little bit of vision on the side. And then if that goes away, then of course you can lose ultimately all vision. We don't want to see that, but you know, that can occur. So in this situation, another analogy we can use the camera analogy, where the retina is kind of like the film in a camera, and you have to transmit that information to the brain. And that's the cable that's where it's transmitted through is the optic nerve. So you can think of it like a camera hooked up to a computer. If you lose the cable, the computer can't capture the image in that situation either. So that's a couple of analogies that we commonly use. It is a common problem in the population, not just in Aniridia, but it's common in a lot of people, a lot of populations to have glaucoma. And one of the challenges is that it's usually asymptomatic. So people may not really know they have a problem, and they can pick it up that maybe the pressures are high, or there's some damage to the nerve or the visual field on an examination. Or they might just start becoming symptomatic. They might start noticing problems with the vision or decreased vision. And that's a challenge, because we don't want it to be, too advanced. So I think what we're trying to do is identify it early, because the treatments for this condition are usually effective. We can usually control the intraocular pressures through a variety of treatments. And so we try to capture it, a little bit earlier in the process. So when we do treat people, we're trying to halt further vision loss, obviously. And then we're also trying to prevent any further optic nerve damage. We have a lot of different treatments to try to achieve this. We have medical treatments, surgical treatments, and the medications that we usually use for this are drops. And then we have various kinds of surgical treatments, including laser surgery, and also incisional surgery, and we'll come back to that in just a little bit. So measuring the intraocular pressure is an important part of the examination for glaucoma. We do really need to know whether the pressure is elevated or not. And so when you go into the eye doctor, they'll use many different methods. There's quite a huge number of them, but I just chose the four probably most commonly used ones in clinical practice here. One example is the Goldmann applanation tonometer that has a little blue light that you can see in the clinic, and it comes very close and touches the eye. So we have to use a topical anesthetic. We have a Perkins tonometer. That's just the same thing. It's a spring-loaded one though, so you can take the pressure on a patient lying down, and that's really useful for examinations under anesthesia, for example. And then the rebound tonometer is a relatively new tonometer that doesn't require anesthesia, because it has a little tiny probe that has a very soft tip, and it doesn't really hurt. So it's tolerated well by children, which is pretty key, because we can oftentimes get pressure readings in clinic that we can use to determine if a child has an elevated intraocular pressure or not. That can be really helpful to minimize the number of examinations under anesthesia that we have to use. In some patients. So the tonal pen is another one. It's a small electronic tip It's essentially a type of applanation tonometry. It does touch the eye. You have to use an anesthetic, but it's maybe it's got a small tip, so it may be a little bit less sensitive to centration, possibly. Although the rebound is pretty good. The downside of it is it just kind of magically produces a number, and you're not quite sure of the quality of the measurement sometimes. So that's not always the preferred tonometer. But when you take any of these different techniques and you can get accurate readings in people, then you can start to get a sense of what's normal or not. And this little graph on the lower right, it shows a picture of all the different pressures from a huge population of individuals that was done some time ago. And essentially this was to collect information to determine what is a normal pressure in the US population. And in the US population, the average pressure is 16. And the standard deviation is 2.5. So if you take 2.5 standard deviations away from that, you get somewhere in the range of, let's say 11, well, 10 to 11, up to 21 is considered to be the normal range. Now, this of course assumes that the cornea is normal as well, because if the tonometer tip if the cornea is too rigid or it's too thick or some other problem, then the tonometer tip may not be able to measure the pressure so accurately. So the gold standard is still applanation tonometry. That's the blue light one. But the rebound tonometer is really useful for us, and we use it a lot. The results of all of these tests are influenced by corneal thickness. And that's pretty important in the topic that we're talking about, because in aniridia, there can be an increased corneal thickness that is kind of normal in individuals affected by aniridia. So it's not the same as the general population, but it's normal in that population. So the average in this series was about, close to 700 as opposed to about 550 for normal eyes. So it can be, very, very much increased, but again, that's sort of normal in aniridia. So yes, that can affect the eye pressure measurements. It may lead to an overestimation of the eye pressure. We do some other tests that you'll hear about or notice, especially as a child gets older, becomes a young adult. We can start visual field testing at around 10 years old or so. Nowadays, of course, earlier, because everybody knows how to use video games and stuff, and so they can perform this test earlier. But we do like to check the optic nerve, and we can take pictures of that. On the lower left, you see some pictures of an optic nerve that is normal. In the middle panel, you see a visual field test. That's what we call functional testing. Is how is somebody functioning with their vision? And what this does is you have to hit a button, see a light stimulus, and then it kind of maps out what you can see. You have the image has to go to your brain, then has to come back. Your brain has to tell your finger to hit the button, right? So it's a little bit subjective in there. There's some, it's how we function. That's what it's measuring. But if you just want to look at the anatomy and see what the actual nerve tissue looks like, we have testing for that too, where we can measure the nerve tissue. And sometimes you'll encounter a lot of clinicians that will take those measurements. And these, we can do those on pretty young children. So it's actually very useful in that population too, where we can actually get a measurement of how much nerve there is and compare that to the normal amount of nerve tissue. If it's a little bit less, then there might have been some damage. So we do want to know that, in most patients. And if it's changing over time, there may be some progression or damage. So we can examine the front of the eye to see where the drain is by actually looking at it directly with a lens. And in this case, we call it gonioscopy, where we're looking through a lens on the eye. We do have to put a lens on the eye, so we have to put a drop of topical anesthetic. And then we actually look at it and we describe it with kind of text, just a descriptive, process where we actually look at it, write some words to describe what we see. There is an OCT image now, optical coherence tomography image, where we can actually just take a picture of the eye and it kind of reconstructs this thing that kind of looks like a CAT scan, but basically it's a similar thing actually, but it images the front part of the eye, that corner where we can't see where the drain is. And in this case, of course, we don't need topical anesthesia, and we have a picture that we can use for documentation. The lower right is a picture from OCT, and this is a person that had a treatment of the iris there. There's a little small opening in it. In the case of aniridia, you'd have an iris stump, but you can still see some iris tissue. And so that's kind of a useful technique for us. So we'll hear this term open angle and closed angle a lot, but when people are talking about glaucoma, and in the open angle, well, basically the the fluid in the eye is produced behind the iris or the iris stump and sort of around the lens area where the lens in the eye is. And then that goes around the pupil and it comes up into the front of the eye or the iris stump and comes into the front of the eye there where it can drain out in the corner of the eye in an area called the anterior chamber angle. You might hear these terms like trabecular meshwork, Schlemm's canal. That's basically all part of this drain from the eye. And in the open angle, the fluid will flow out there. The iris is not blocking the drainage, and that's the lower left picture. But in the lower right, the iris is kind of bowed up there forward and it's kind of covering up the drain in the eye. And so that would be a closed angle. And the idea there is the iris tissue is closing off the angle. And that can happen a lot of different ways, but that's the basic idea there. So we do have, in aniridia, we do have some different mechanisms. It's not very common to see glaucoma in infants, but it does occur. You saw that picture earlier. But it's much more common in childhood and early adulthood. And most of the time, almost always, actually, it's an open angle glaucoma. So these are images of an aniridia situation where there's a shorter iris there, but there is some iris tissue. And the fluid on the top, it can go around that iris tissue and go out through the drain. And the bottom one, though, that iris stump can actually cover up that area. And that's pretty uncommon. We do see that now. We know, there's a citation here to a paper from 2019 where we really feel confident with anterior segment OCT images that the open angle glaucoma is the most common form of glaucoma in aniridia. But you can occasionally get secondary angle closure. So if somebody has an eye surgery, then they might get some scarring and some closure of the angle in that situation. But otherwise, we just really don't see that. And so we think of it as being mostly an open angle glaucoma. In aniridia, it's clear from previous studies that glaucoma occurs in at least 50% of the patients that are affected with aniridia. And the age of diagnosis for the median is 8.5 years. And what that means is that if you look at a group of individuals with aniridia, and you look at those individuals that have glaucoma, about half of those people will develop glaucoma by 8.5 years old. So that's a good kind of thing to keep in mind about the age. So the glaucoma treatment, it does, in this group of individuals that gets glaucoma, they frequently have to have treatments. Glaucoma medications are used in the majority, if not all patients at some point during their clinical course. And in this particular instance, with this one slice of time, it was 76% of the people with glaucoma were being treated with glaucoma medicines. And about 58% of them had glaucoma surgery. So the majority also have glaucoma surgery. The office examination is pretty important in this group. Because this can happen during childhood, it's important to try to monitor any child with aniridia periodically to see if there's an increase in intraocular pressure. We recommend about every 6 months. But we do try to get as much information as we can on these clinic visits. So we do try to get an accurate pressure. For that, we're using increasingly the rebound tonometer. We used to sometimes, if we couldn't get all the information, we'd sometimes use a sedative in clinic. Really can't do that anymore for practical reasons. So if we have to use an anesthetic, we have to consider doing an examination under anesthesia. And that's a big step. And so we try to get as much information as we can in clinic. And nowadays we can get almost everything we need, for most clinic visits, because of the improvements and all the things that we have. See if I can get that to advance. Yeah, so the frequency of examinations, we're recommending about every 6 months. But if the pressure goes up, it might be a little more frequent. Maybe the doctor will say, well, come in 2 months because we're kind of concerned about the pressure. It might be a little bit borderline, or it's fluctuating, maybe going up. So they'll sometimes recommend a little bit sooner than that. And certainly the challenge is that glaucoma can develop even though you have an examination where everything looks great and the pressures are good. It might be 6 months later, the pressure can be a little bit elevated or borderline. So that's why we always have to watch out for it, because just the biggest risk factor is just time and age. So the treatments, we do use drops a lot. The type of lasers that we use for adults with open angle glaucoma, that other population that of individuals that doesn't have aniridia, that lasers can be very helpful, but in aniridia, it's not really that useful usually. But we do have incisional surgeries that can also help, especially in those patients that don't respond well to medical therapy. So it can be really important to go to some kind of surgical treatment to prevent damage in some patients. So in that situation where, we have a lot of options, if the medical therapy doesn't control the pressures, the exact procedure does depend on the individual aniridic patient to some degree, but there are really some strong trends. I think most clinicians are steering away from the so-called, I'm just going to say a couple names and then we can talk about it later if we need to clarify, but trabeculectomy, you'll hear that name sometimes. I think they're steering away from that. We're in an era now where glaucoma drainage implants are probably used most commonly. Sometimes we will use a laser. This is the cyclodestructive procedures are now kind of laser based, and we can recommend a laser, but it's a different type of laser than is used with other glaucomas. And it's a really good procedure to combine well with the previous drainage implant. So we use it in certain situations, maybe as an adjunctive treatment if we need it or something like that. But we don't, we don't rely upon the laser procedures usually. There are some other there's a lot of new work and effort being made in the minimally invasive glaucoma surgeries, especially the transscleral MIGS, and I'm using a bunch of terms, but basically the idea is that these are surgeries that are less invasive, easier to recover from, and relatively safe. So I think there's a lot of interest in these. We've certainly found them to be helpful in aniridia, but it's relatively early in the experience with this, and so time will tell exactly where we want to use this, but it has been useful so far. And on the other hand, we're finding over time that goniotomy, perhaps that's another thing you might hear about, where you make an incision in the drain part of the eye, or trabeculotomy, a similar thing where you kind of break open the drainage part of the eye. Maybe not as helpful. It tends to heal in, and it doesn't give a long-term effect a lot of times, and it can cause that scarring in the angle that we're talking about. So, we tend to rely a little bit less on that. So, as I mentioned, I'm going to try to keep this part short because we want to open it up for questions and just discussion. So I'm gonna just summarize all the things that I've said here by saying that aniridia is often associated with glaucoma. It can cause progressive visual loss that can be irreversible. So obviously you want to try to catch that before you start having any damage, or identify progression or damage if it's ongoing while it's occurring so that you can stop it. And so that's really important to have that medical care, in that situation. Patients often require surgical treatments. The treatments usually have good outcomes now. So I would say, generally speaking, we can control the pressures, which, limits the damage in most instances. Technically, and I saw some questions a while ago where, does it really get rid of glaucoma? But it doesn't actually necessarily get rid of the glaucoma, but it can control the pressures, which prevents the damage. If the surgery, let's say, just stops working for some reason or whatever, then you still have the glaucoma there, and then you have to find some other way to drain it. So, but it can be very critically helpful to control the pressures. Monitoring and prompt treatment can prevent vision loss due to glaucoma and aniridia. And certainly the new surgical and medical treatments are promising. There's a lot of research in this area. This is something where there's a lot of focus right now in the glaucoma community. And even in aniridia, where there are some challenges, we're finding a lot of promising approaches here that should be relevant to all of us in the aniridia community in the future. So I just wanted to stop there. We'll try to take some questions. Before I do, I'd like to thank Aniridia North America for having this focal point. I think it's really important, and I'm just thrilled to be part of it. Aniridic Family, International Wagner Syndrome Association, that's IWSA, Vision for Tomorrow, VFT, Aniridia Europe, where ANA is partnered with Aniridia Europe, and that's gonna we believe will be an important partnership in the future. And of course, for me, I as Janelle mentioned, I see a lot of patients and I see a lot of families with individuals affected with aniridia, and I am just grateful to the whole community. I really care about my patients and their families, and so I'm grateful to them. My collaborators too. I've consistently had some scientific collaborators that I'm really grateful to. It's been really great to work with them and try to explore areas that we don't understand very well and try to get a better understanding of it. So I'm grateful to all of my collaborators too. So anyway, with that, on that note, I'm going to stop and I'm going to stop screen sharing so we can just talk. And I'm looking forward to this part, and we'll just see what what kinds of issues are on everybody's minds. So I'm going to stop screen sharing. Here we go.
Thank you, Dr. Netland. That was fantastic. We so appreciate all that information. So many people sent in so many great questions, Dr. Netland. So we are going to get through as many of them as we can tonight. If somebody is on here and they think, wait, I haven't heard my question yet, please know that we consider it important. We're going to do our best to address them now. If we don't get through them tonight, we will find another method to do our best to address them at some point in the future. So for right now, I'm going to get started, Dr. Netland, with a question from Diana in Alabama. She actually just put it here in the chat, but she had also submitted it, and I think it's a good one. If the rebound tonometer in the office shows a normal pressure and no other abnormalities are found, do you think it's necessary routinely in all babies with aniridia to perform an exam under anesthesia?
Well, that is a great question, Diana. It depends a little bit on the clinical situation. There may be some things that the doctor is concerned about that maybe are more than just the pressure. But a lot of times you can get the information about those other things during the office examination, even with a small child, an infant. So I think it does vary a little bit. But for the most part, if everything else is okay, the cornea is clear, the clinician can see the back of the eye, the optic nerve looks pretty good, and then the pressures are really normal, and the doctor feels pretty confident, gets a couple readings maybe even, and finds that, yeah, they really seem to be normal, or even takes it one step further, maybe just does a tactile estimation of the eye pressure where you kind of take your fingers and feel it a little bit, and if you feel all those things are convincing the clinician, as a clinician, if I feel convinced, yeah, I think it's good to delay the EUA. You probably don't need it. You've got most of the information you need to know that the child doesn't have glaucoma now, and everything else looks like it's pretty good. So but there are situations where they might say that something else doesn't look like they need to get a better look, or they can't quite get the examination they want. And I'm thinking specifically of maybe lens problems or retina problems. But for the most part, I think you make a good point. If the pressures look pretty good, then, and that's what you're looking for, then you can probably hold off on the EUA. So I think that's a increasing trend that you've identified there. That's what seems to be going on with clinicians. Okay,
great. You mentioned basically using a tactile measurement kind of the pressure. Tiffany from South Carolina had asked, is palpation like that more accurate to detect elevated pressures than a tonopan, or is it less accurate? Or does that depend on the clinician's experience?
Yeah, well, I don't know if it's more accurate, but it can be really helpful because, I was mentioning that you might have an artifact in the reading from a machine that might be from the corneal thickness or some other artifacts too. So anytime you get a number on the machine, and the rebound is another one that just kind of displays a number, it's always good to get a sense of whether that actually seems to correspond with, with other ways to back up that impression, just so that you make sure you don't miss something really, really important. So I think the feeling it can be good as a way to corroborate the finding, to say, well, the rebound says that it's 25. Does it kind of feel like it might be 25, or does it feel like it's 10, or, so, and the tactile estimation is not very accurate, but it can tell you those really big differences. Like if you're looking for somebody that has a pressure of 50, you can pick it up on tactile estimation. You may not know that it's 52 or 51 or whatever, but you'll know that it's in that zone, which is bad. And then if somebody has a low pressure, it's super soft, then you can usually feel that too. So you may not be able to tell if it's the pressure 16 or 17 like you can with a tonometer, but it's really important to back up that measurement, especially if you're finding that something is clinically suspicious and you're going to try to do something like give a medicine or whatever. It's really important to know that you have confidence in that number. So yeah, I think it's not quite as accurate as the other ones, the machines, but it's a good way to corroborate it. And we have corroborated, and we have sometimes when we have to do tactile estimation. And an example of that would be if we have a keratoprosthesis. we're getting some new techniques that can come in on the side of the eye and try to measure the pressure and various things like that. But it's still an issue because we can't use these conventional machines to take the pressure off the cornea because that's plastic. So it doesn't, measures a super high number, but it doesn't have any correlation to what the pressure is inside the eye. So I think that's a great point. We do use it. I think it's probably better. Maybe we would say that the machines are more accurate, but you just have to make sure that you're getting a valid number, when you have that measurement.
Speaking of numbers, Wendy from Michigan and a few other people had asked, okay, what is considered too high a pressure? Something that we're concerned about, like when do you need to start drops for somebody with aniridia?
Yes, that is a really important question. So we've had, I'm just looking at some of the notes that somebody sent one point talking about, you'll get this feedback if the pressure is, one person was saying the pressure might be 15 and the doctor says I need drops, or I measured it at home and I got like a 19, the doctor says I need drops. Well, those are normal numbers, and you really have to take that with a grain of salt. So I'm not sure that you have to take a medicine, because the pressure is 16. In fact, I would say that's pretty normal. What is too high? It's helpful to know your corneal thickness, because then you can interpret that number in the context of that. So if the corneal thickness, like an aniridia commonly is 700, 750, even 800, well, that's a little bit higher than average in the population, general population. So you might add on a little bit to that. We don't have a direct algorithm that will convert the numbers based on corneal thickness, but we have some estimates, and it's going to be a couple millimeters higher reading than what you would otherwise get. So you might say that maybe you want to keep the pressures in the normal range all the time, which would be 21 in an individual without aniridia. But you might say, well, give them a break. Maybe it's 25, that we want to shoot for because the corneal thickness is so high. So it's helpful to know that. I think generally speaking, for me, if I get up around the 28 to 30 range, I do get nervous, even if there is a thicker cornea. And I really want to be watching, even if it's over 25, I want to start watching the nerve. And a lot of times I won't launch into treatment there, and many clinicians won't. But if they start seeing changes in the nerve or any other findings like that OCT test or anything, where there's some evidence that there might be a little bit of changes occurring, well, then it probably is important to start the drops. And I would say that usually eventually trumps the number in every case, because I'm not trying to be political here. I just use that word, it comes over, it supersedes the number, because basically if you see damage occurring, then you have to lower the pressure to some extent. So that's why we get in this situation where if there's advanced damage, we sometimes recommend even mid to low normal pressures. So it has to be interpreted in the context of how much damage there is and other things. But basically, so you'll see the number will vary. But I don't always agree with treating a normal range pressure unless there's a lot of damage in aniridia. But if the pressures are above quote unquote normal, you still have some wiggle room a lot of times, and you can oftentimes safely monitor a person, even with a pressure of 25, 26, 27, whatever like that, in some instances with a super thick cornea. But then really above that level, you really have to be monitoring very, very closely to be prepared to start medicine, or just go ahead and start drops, once the pressures get higher. So I hope that explains it. Okay. In other words, not a single number, but,
No, that's very helpful. So speaking of drops, let's say we first started drops on somebody for the first time. How quickly do you want to see them back in the office afterwards to see if it's working, see if you need to change, etc.?
Right. Great question. So usually we're going for, you have a little wiggle room with the timing on it. It doesn't have to be an exact amount of time, but usually I'm going for 2 to 4 weeks, what I'm doing. And sometimes I'll go 1 to 2 months if I feel like we're not in any great danger of having any damage during that period, especially when we're starting the new medicine, if it's likely to work. So I'll give a little bit more time. But I do think that it's really important to check it to see if you're having an effective reduction of the pressure. Important to look for side effects. So you want to check on it, and you start to get a good feeling of that after a couple of weeks with most of these drops. Some of them will have an effect within a week, but most times I'm looking for 2 to 4 weeks. There is one category of drops that takes a little longer to kick in, and so you'll see some clinicians, if they give you a prostaglandin analog, a latanoprost or something like that, they'll say, well, we'll check it in a month or 2. That's a little bit different because it may take longer for that drop to kick in. But for the most part, we're talking, 1 to 2 months. We'll know the answer if it's working or not.
Okay, that makes sense. And again, speaking of drops, Tara from Illinois asked, can you speak to using preservative-free drops? Is that an important thing for analytics for glaucoma drops? And how would we know which drops to avoid if that is important?
Right. That's another really important question. The preservatives can be helpful to have efficacy of the drops because sometimes they help the drugs penetrate better through the cornea. But I know, and rightfully so, the cornea specialists especially are really nervous about the preservatives sometimes because they can be irritating to the cornea a little bit. So it's really that kind of negative and the yin and the yang. So that we have in that situation. So I think from a glaucoma person viewpoint, I would say that it's preservative-free drops are pretty common. Preservative drops are pretty common, and they can be very effective. And I'd say the majority of people don't have an intolerance to that. But in the situation in Aniridia, a lot of the cornea specialists say, let's be a little bit more delicate on the cornea. Let's not try to push that and use a milder drop. And I really do kind of agree with that. I think it is good to sometimes do that. They are a little more expensive sometimes, but you can get preservative-free versions of most drops. And I think it's a very helpful way to go. Having said that, there's not always bad, and there can be situations where you can tolerate very well. Many people can tolerate really well a preservative-containing drop, and they're usually much cheaper, more easy to use. Like you don't have little packets, you might have a bottle you can repeatedly use. So there's convenience, there's cost, and when those factors become important, sometimes it is okay to try the preservative-containing drops.
Okay. Speaking of drops, Natalie from Texas asked, is there a downside to being on them long term? Like, do they become ineffective, or can you be on them for a long time? Somebody else had asked that as well.
Right. Generally speaking, again, a great question, because generally speaking, it's if you can stabilize on drops for a long time, that's great. In other words, not needing to have surgery. That's great. Postpone the need for that. If a child is young, it's great to get to a little bit older before they have to start worrying about things like that. And it's a wonderful thing. Having said that, there are some studies that have shown some kind of chronic irritation from drops. And I think we can all understand that. It's a little bit, they're chemicals. I mean, they might be a little bit irritating. And so, but the trade-off there is that sometimes it really is good to not have to go to a surgery, right away. And even for a number of years, it's great to let somebody get older. So there's always a little bit of concern there about the chronic effects of drops. There is some evidence that they might cause a little bit of inflammation, but there's not much evidence in Aniridia that affects outcomes of surgeries later and things like that. So we can't really see that inflammation, but if you look at studies where they look at tissue from eyes that have been treated for a long time with medicines, you can see a little bit of evidence of some chronic inflammation, and we're concerned about that. So ideally, sure, not being on drops is great, but sometimes not being on drops is better than going ahead to some kind of surgery. So a lot of times we'll keep on them, and if they can control the pressure, we're happy with that. And if we can stabilize for a while, that's great. But it's a good point, because we do think about that. And if you see redness, if you can see the redness, we usually try to find an alternative drop or find some other solution.
So in theory, could you be on drops for 20 years, 30 years and have
We
it
do,
controlled?
believe it or not. Yes, believe it or not, we have some people that are on long term, and also some of those statistics that I showed you where people can be on the majority of people with glaucoma have had some kind of surgery but are still on drops. So if the glaucoma is getting worse later and they need a little bit more than that surgical treatment, maybe somebody will be treated with a drop. So yes, they're commonly used. They can be used for long term. And fortunately, most people can tolerate them really well. So we don't have major issues. You can use preservative-free or preservative. Most people can tolerate it, and it can be a very helpful adjunctive treatment to kind of keep the pressures under control, even after surgery sometimes. So yeah, so people can be on them a long time, but we always try to get them off. If they're having a surgery, we try to get them off drops, because it is better to be off drops, really.
If we can, absolutely.
Yeah.
Changing gears a little bit, somebody asked, Jana from California asked, does the artificial iris implantation surgery, does that increase the risk of glaucoma?
Well, that's another really wonderful question. The numbers are relatively small, but it does appear to perhaps increase the risk of glaucoma. It's hard to say. Certainly, it increases the risk of fibrosis and other problems too. So there is a certain rate of problems that are associated with the artificial iris. In other words, it's not complication free. And so you have to kind of weigh that in when you're deciding. It's a really tough decision because there are patients that have it that do pretty well. And there are some that do have some challenges with fibrosis and some that have it can worsen the glaucoma. So I do think you have to weigh that decision very, very carefully, and we can provide more information later. But yes, there's a downside and an upside. And I think right now I would say probably the trend is a little bit away from the implants right now because of the concerns, but some are used, and I think it can be appropriate in some situations. So I think that's the kind of thing that we'd probably have to talk a little bit more offline about, because knowing the individual situation is important.
Absolutely. All right. So a number of people, I can't even name the number, have asked, are there ways that we can help our little ones prevent getting glaucoma, whether it's foods that help or supplements or natural ways or anything like that, things that we can do to help prevent it?
Right. Well, certainly we talked about preventing damage and just doing the monitoring and the 6 months exams. But in terms of preventative treatments, we're pretty limited because the eye pressure seems like it's kind of insensitive to things like blood pressure. If you have too much salt or, a lot of things, diet things can really influence it a lot. But the eye pressure seems a little bit less sensitive to that. So it's hard to really alter it with with dietary things. There are a couple of things that can improve the pressures, but maybe not totally prevent glaucoma. So exercise has been found to have a small effect, maybe a couple millimeters on the pressure readings. Stress is now becoming identified as a possible. They've found ways to study stress. It was always hard to do before, and they've found some actual studies that have shown a couple millimeters of reduction of pressure if you do stress reduction things like mindfulness, meditation, or whatever. But so there's very few modifiable risk factors actually. And so in other words, there's very little you can do. It seems like drinking coffee, drinking fluids in general, unless it's massive amount of fluid, you can't really seem to alter the eye pressure that much. And so most of the food and drink, has not been found to have an effect. So that's kind of frustrating because we'd like to have an easy answer like that. But having said that, there are some things that people can do to modify it a little bit, and that can be helpful in some situations.
Okay. I guess the corollary to that, is there anything that somebody with aniridia shouldn't be eating or drinking, or medicines they shouldn't be taking because they're likely to contribute to the high pressures?
Yeah, that's a great question. So eating or drinking things, regular food, no problem. I don't think there's anything that's going to be causing damage that's known about. The medications, though, you mentioned, that's a different story. There are some things that can cause problems. Any kind of steroids, if there's an asthma situation and somebody's on a steroid inhaler, that can affect the eye pressure after a long time. And there's other drugs too. I don't think many patients are on some of these ones that cause rare side effects, but topiramate, things like that, but they can actually cause glaucoma. So you always have to read. And then there are ones that are on a lot of bottles, but are less likely to cause glaucoma and aniridia. So for example, Benadryl, don't worry about that one. You don't have the risk for glaucoma in that one. But there are some drugs. So it's always good to check with your doctor. If that label says that, glaucoma may be a risk, then it's good to check it out. So I think medications, with a medical opinion on it, just for that specific drug, medications can be a risk. And, we certainly do see patients that get medications that can make the pressures worse or cause a glaucoma situation. So,
Okay.
if you read the label, check them out.
Somebody asked about caffeine specifically. Is that something that can contribute to pressure issues?
That's been kind of intuitively, we all think that should do something there. It's been checked since probably the 1960s or 70s. There have been a lot of research studies that just looking at that, along with a lot of other medications that sort of you intuitively might think might help or not or hurt. But yeah, caffeine has been looked at for a long, long time, and there's never really been any evidence that it influenced the eye pressure much at all. So it's actually really, you're free to drink caffeine. There's no restrictions. We don't put restrictions on that. And I mean, within reason.
Right.
But like anything, I guess, but yeah, I would say that that's one that's safe to have, and it doesn't seem to harm the eye pressure.
All right, and somebody else, Ryan mentioned that he had heard of a study mentioning magnesium supplementation as a potential treatment. Have you heard anything about like those kinds of supplements as a treatment?
Right. So there's been a lot of interest, and I think what I'll do to summarize it all up is that there have been individual studies on most of the vitamin categories, many vitamins, and also some of those salts, like magnesium salts, sodium, all kinds of things have been looked at. There's really not a lot of evidence that it definitely helps. If something isn't going to hurt, most physicians will not suggest that you avoid it, because if it's not going to hurt you, we don't mind if you take it. But there's not a lot of evidence that it helps. And some of the individual vitamins have been pretty interesting to people because they might offer an occasional, what looks like a benefit in some small group of individuals, but in bigger trials, they don't seem to really offer a lot of help. And in particular, in aniridia, individuals with aniridia, it's hard because there's none of these vitamins have been proven to be effective. Having said that, what doctor would ever tell you not to take a vitamin? As long as it's not one that's going to have toxicities like a fat soluble vitamin like vitamin A or whatever, you can,
Sure.
it's not going to hurt you. So we don't mind if you take it, but it's probably not going to have a big effect on the glaucoma.
Okay, let's switch gears a little and talk surgery for a minute. Does glaucoma surgery potentially increase the corneal scarring or the corneal keratopathy?
Yes, so that's a great question. So there is the potential there. I think most of the doctors are really trying to be sensitive about that and avoid things that can do it. Obviously, like a cataract surgery might have a corneal incision that's going to cause some localized scarring there. But the idea is we try not to do things that will maybe cause damage to what are known as stem cells, or things like that. And I think most of the clinicians are pretty careful about that and try to avoid damaging things. But it is possible to have things that can cause effects on the cornea. And I will tell you in the glaucoma surgeries too, I mentioned the tubes, they're commonly used. That can go near the cornea or touch the cornea if it moves a little bit, and it can cause some localized edema or fluid in the cornea, causing a little bit of haziness to it, and especially in just one localized spot. But if that spreads, it can cause an effect on the vision. So I think, and it may require treatment. So we're always on the lookout for those things because it's a great point. Yes, it can have an effect, and we always have to make sure that the situation is safe, and we don't have to correct something to make sure that it's not causing some adverse effects too. So it's a great question.
Okay. Another one related to surgery. Is there an advantage to having glaucoma surgery and a cataract removed at the same time as opposed to doing them separately? That came from Rex in Tennessee.
Yeah, that's a great question too. It's becoming increasingly popular because now we're using more surgeries that can be minimally invasive. Now, I think the idea of having the drainage implant, which is bigger surgery plus cataract surgery, that's a lot. And so a lot of times we'll break that up into 2 steps. And treat whatever is more important first. If the cataract is worse, we'll treat the cataract first and then treat the glaucoma later if needed. And if the glaucoma is worse, we go ahead and treat the glaucoma and then treat the cataract later if needed. And it really depends on how much treatment is involved. It's a lot to have a drainage implant tube plus the cataract surgery. So a lot of times we do try to break that up. But with the newer surgeries, it may be faster recovery, minimally invasive, and so it's becoming very popular. In fact, I do it myself. I'll do a lot of in non-aniridia situations. We'll do a lot of cataract surgery. I just had surgery all day today, and we do a lot of cataract surgery with some of the new minimally invasive surgeries. Now that's being now used in aniridia as well, and that can be a benefit. So I will say that in the situation where there's a cataract surgery now, we always think about that now because we can offer the same kinds of things with minimally invasive surgeries in combination with cataract. I'll just tell you that I think it's not so common now because the aniridia usually has the glaucoma has a different age of onset. In aniridia, median age is 8.5 years. Cataract, average age of surgery is in the 20s. So it's just the timing isn't that great to do the combination because a lot of times people don't have issues with cataract when they have the glaucoma problems. So we'll focus on the glaucoma. But I hope that answers the question. But yeah. Yes, you can, but it depends on the situation. We don't do it as frequently in individuals with aniridia.
Okay. Joel from Maryland asked, can you please briefly describe how glaucoma treatments have changed over the course of your career?
Oh yeah, that's a great question. Tons. They're just much safer now. I think that's the biggest difference that I've seen. In the older days. It was really stressful for the doctor and the patient because we'd have really low pressures after the surgery, sometimes too much flow, and sometimes we'd have too little flow, and it was just really a challenge because we didn't have as good control. Now I would say the current treatments are just so much safer. They're actually more effective because of that too. Because if you don't have the pressure's going too high and it sort of starts to not work as well, well, I guess you're going to have better efficacy as well, because on the average, you're going to be doing better with your pressures. But having said all that, the main issue the way I see it is just safer. And that's been a really good thing for patients. It's gotten much, much safer over the years.
That's fantastic. All right. So if you've had surgery and you have Ahmed valves on both eyes, how frequently should we go to a glaucoma specialist then? I mean, we talked about if there were no issues, right?
Right. So that's depends a little bit on the situation. So the pressures are pretty good. And what you're saying is this a person that has had implants, things are good, under control. So we do still recommend about 6 months. We'll get up to about 6 months. We're still recommending twice a year if you really have glaucoma, in the best case situation, because if you go a full year, that's enough time where you might have something that might change with the flow. Maybe it's rare to see problems with the drainage implants long term, but if you do have one, you might go a full year without having it picked up. So we want to make sure the pressures are still good, twice a year or so. And then usually that's our kind of routine. So even if it's a pretty good situation, stable, we still like to check it once or twice a year. You can also do that in combination if you live a little bit of ways away from the glaucoma person you're seeing, or the person who's taking care of the ophthalmologist taking care of the aniridia. Sometimes you can have an optometrist check a pressure at 6 months. And if it looks good, do a follow-up in a year in the ophthalmologist, then 6 months at the optometrist or something like that. But it is good to get a pressure number maybe twice a year, even in that situation.
Okay, I think we have time for a couple more questions. One, a number of people asked, what are the most important things as like a parent that I can do before glaucoma comes to help protect my kids' vision? What are the most important things?
Yeah, great question. I think there's I think the main thing is just to monitor things. Probably that's the number one thing. Keep the child comfortable, obviously, with tinted glasses or hats or whatever, but basically, try to keep the child comfortable, but keep on the monitoring to make sure you don't miss a medical problem that might cause a problem. I think, when people do go into the eye doctor, another question that we had is what questions should we be asking?
Yes.
And I think it depends a little bit on the situation. If it's just just checking to make sure that there's not a problem, you just want to know, is there a problem or not? And if there isn't, I mean, you want to know more, obviously, but is there a problem or not? And you do need to get the answer that things are okay now, so you can continue the routine monitoring. If there's a problem, you want to know, like, let's say the pressures are up a little bit or whatever. You want to know. I think a good question to ask, a reasonable question, is what is my child's corneal thickness? It's not difficult to measure, and that can help you interpret that number. And I think another good question is there damage to the nerve? Is there a pressure problem that's causing damage or glaucoma? And that's something that's fair to ask too. They should be able to look at the nerve and tell you if it looks okay or not. And then I think the other thing is that other more refined questions like that are like, is there visual field damage and stuff? That, you can ask a lot of questions about whether or not the pressure problem is causing damage. And that's really important for you to know as a parent. So I think there are some things that are you should ask, really, if there's any problem picked up. But really, if it's routine monitoring, things look pretty good, and you are not picking up any kind of functional problems with the child, they're functioning well at their baseline, then that's great. And I think that's the main information you need to know there. But if there's something picked up, you want to ask about it. I think it's really important.
Okay, let's kind of change gears a little bit to the opposite problem, not having enough pressure in the eye. Is there any way to like improve that, even if it's been a long time? Joylyn was asking, or is there not?
Yes, there are a lot of different things. A little bit of it is what depend on the situation, what is causing that. And so the first thing we look for is why is the pressure low? But let's say we have an answer that it's maybe overfiltration, or too much fluid coming out. We can try to make adjustments there. There are surgical treatments that a lot of times we'll start off with just simpler treatments. If there's, we can use various kinds of simple things we can do in clinic to improve that in many instances. So we try, things to help reduce the amount of flow, and like things like a blood injection, patch blood of blood to help it to stick down better and reduce the amount of flow out of the eye. Other things that are simple we can do in clinic. And then if that doesn't work, we can do some relatively simple surgical things. We can tie off tubes, we can do all kinds of things. So we try to adjust the pressure up if it's enough so that it's causing problems with the vision. So if it's enough, if it's low enough so it's causing some damage, we do try to adjust it up. And we have many ways to do that. Sometimes it involves a surgical treatment. Usually they're not very big surgical treatments, but they are usually smaller things, but they can be helpful to get that pressure up so that we don't have any blurring of the vision or problems with the retina.
Okay, I have 3 people wondering if we have failed valves, like an Ahmed valve, do we leave them? Do we remove them?
Right.
Does it depend?
I would say normally they're left there for a lot of reasons. They're a little bit, once it gets all healed in, it's encapsulated, right? So it's a little harder to remove it. But the other reason that they're oftentimes left in is because they're not causing a problem. And the other thing is that they might be helping a little bit. So the pressure might be going up because just generally the drainage is getting worse and worse and worse. There may be some flow through the implant, maybe a significant amount, but it's not enough. But it is helping to some degree. So a lot of times clinicians will leave it in for that reason. But if it's causing problems, we try to remove them, causing anything that might be potentially damaging, we want it out of there too. So we'll try to remove them in that situation. But a lot of times if it's kind of borderline pressures, but it's still sort of functioning, we'll just do a laser treatment to try to bring the pressure down a little bit better. And the person doesn't need more hardware, but they can use the function that's there to help them. So, a lot of times I'd say we're not really removing them, but just occasionally if they're causing a problem like damage that might be damaging the cornea or something else, or it might be extruding coming out, then we want it out of there too. So we'll remove it in those situations. But if it's not causing a problem, it might be helping, and often we leave them in.
Okay, I have time for one more question. So 2 people asked, on the horizon here, what are the best things that you're seeing? Like, is there progress in the research? Is there a possibility of a cure? Possibility to just prevent this completely? What is out there?
That great question there, because it is an exciting time. We're seeing a lot of other areas I'm not going to talk about because we may talk about cornea and things later, but I'm really excited about that. I think that's a really frustrating area for individuals who have aniridia, and there's a lot of exciting progress there, a lot of exciting progress in other areas too. But I do think for glaucoma, probably our focus in recent years has been on treatment, and the surgical treatments have gone through a revolution. I mean, we're not using the things that we used 10 years ago at all. And we are using drainage implants, but they're just so effective that we still use them a lot. But we're using a lot of minimally invasive treatments. Those have been turning out to be increasingly effective. They're very much safer. They're very safe. And we've really found radical changes in how we manage things. So I think the medicines are also changing a little bit, not as much, but we are seeing on the treatment side of it a lot of new things. What causes it originally? There's a lot of work going on there, but I don't think there's anything quite practical yet. But that's an area that we need to focus on more in the future to try to get it so that we don't have to deal with these things, in the first place. So yeah, there's a lot of room for more work in that area. How do we prevent kids from getting the high pressures in the first place? So that would be great, and we're a lot of interest in that, but I don't think we have the answer there yet. But there's a tremendous amount of genetics work being done on the things that might influence that drainage part of the eye and how we can get that better. And there's a lot of potential there, just no answers that we're using right now. But I think the treatment side, really exciting, a lot of new things that are safer, better, and effective. So it's really been great.
So there's a lot of great improvements, which is very hopeful for all of us, right? That's fantastic. All right, so we are kind of out of time. However, before we leave, I'd love it if everybody could turn on their camera. I'm going to turn off the focus mode and the spotlight mode, so that hopefully everybody can turn on their cameras and we can see you all. So let me see if I can make that happen here. Let's see here. Maybe, is it working?
Oh, I see a lot of screens. There's actually 2 humongous screens. So that's great. And I'm excited, if you're at home in your pajamas, you don't have to turn it on. But if you do, it's great.
Right. Let's see if this will let people turn on.
Now
their
I'm
cameras.
seeing
I think so. I think it's starting to work.
Yeah, I'm seeing a lot of my friends too. It's awesome.
Right? Me too. I'm seeing a whole bunch of people that I just really enjoy. So this is kind of fun. We're going to see how many we get, and then we'll maybe take some screenshots of everybody. Oh yes, I'm seeing all kinds of friends. This is wonderful.
This is awesome.
So
Yeah,
fun.
there's a ton of great friends here. So
This is great.
I saw, I think Patty Ganaway there earlier. She must be on the other screen. I'm going to check out my other screen here. Wait a second. I'll come
Absolutely.
back.
Why don't you do that? I'm going to start trying to take some.
Yeah, that's cool. So yeah, well, while Janelle is getting the pictures and stuff to take the screenshot of all of us on, I just want to say thank you all. I guess I'm hoping we can do this again because we don't, we got a lot of really good questions, and obviously we need to spend a little more time just talking. So I would love to do that. I didn't monitor the chat, but there's like 30 things in the chat. I'm going to look at them later.
Yeah, and we had a number of them that we didn't get to on our list. So I'm thinking, Dr. Netland, we might need a glaucoma part 2. How do you feel about that?
Yeah, part 2, we're going to have to do it. And the other thing is we'll try to, I'll work with Janelle to try to get through, some more of the questions, see if we can get the feedback somehow, because they're really, really important questions. And so
Absolutely.
we want to get to them. And so we'll try to do our best to get these. And also we'll do it again. So it's great. I love this picture.
I think I got some screenshots here.
Wow.
It's so fun to see
one with
all of
everybody doing
you.
a thumbs up. That would be kind of fun, or something like that. My reactions too. I can get a bunch of thumbs going up there.
That's fun.
Yeah. So we can get one more here. Here's a thumbs up.
Yep, absolutely.
There we go. We can do one of those. You got
Excellent.
Good.
Oh, this is fun.
Yeah, that is pretty.
It is wonderful to see all of you on camera for a bit, and we hope that this was really helpful. Thank you all for joining us tonight. We like Dr. Netland said, I think we have enough questions for another episode, so we will try to schedule one of those here in the coming months. And we will also we've recorded this, so we will be posting this online. We're going to create an ANA YouTube channel, so it's going to go up there and it'll go on the ANA website. And we will just continue to move forward. And hopefully if you have, I wanted to make sure you knew, if you have suggestions for future episodes, topics that you want to see covered, you can email those to focalpoint@aniridiana.org. And we will receive those and put those on our list. So thank you all so much for joining us. It's always heartwarming to see you all here and to remember that, we might be alone, we might be rare, but together we are much stronger. Have a good night, everybody.